Okay, good morning. So before I start, just a show of hand, how many people here know what MIPS is or have heard of MIPS? Okay, how many people think they really understand MIPS? How many people know what FHIR is? Okay, that's just to make sure my accent is not a problem here. So, what we're going to do is I'm going to do the fastest ever crash course on MIPS, just to make sure everyone understands what we are talking about. And then MIPS, basically quality program, all part of it. And then we're going to address some of the burning issues around MIPS. And we're going to finally talk, obviously, about how FHIR can be used to extinguish some of those issues. So what is MIPS, or what is quality payment program, or MACRA, or so really in a single sentence? It's a program that was started this year by Medicare, where the Medicare Part B providers are going to have some payment adjustments applied to their payments based on their performance. And this is not the first time, a performance-based program has been started. What is really different about MIPS or unique about MIPS is that this program is based on a scoring system. So every provider in the country is going to get a score, and that score is going to be compared against the peers, against all the providers, and that's going to determine what the payment adjustments are. More importantly, that score is something that is going to be public. So it's going to be published on a public website, and all the patients, everyone is going to have access to the score. So it's a pretty big deal. I mean, that's kind of the point in there. And the part that becomes really important here is that score, a major part of that score, which is the quality performance of it, it's really not proportional to the performance rate. What I mean by that is there are ways in which two providers having the exact same performance rate in same measures might end up with different scores. And the reason that is because just like the way we are taught in medicine is it's not what you did, it's what you documented. So when it comes to MIPS, it's not what you did, it's what you reported, and more importantly, how you report it. It really matters. The methods basically, both those factors matter a lot. So to show you an example here on the top part of the screen, I have two basically different quality measures. Both of them have a performance rate of 90. The first one gets 10 points, the second one gets 4.4 points. So the second column there is the number of points that particular provider is receiving. So both measures having the same performance rate, drastically different in the points that they are getting for that. On the bottom of the screen, what I have done is that there are two different quality measures where the graph is plotted for the different submission methods that they were used for it. So claims, registry, and EHR. And you can again see the difference in there that basically based on the method used, there's a lot of difference. Now, why is it there? It's a big discussion also, but the basic idea there is that CMS determined that there are some measures that are easier to score, so there are some benchmarks applied, and then they also want to make sure those benchmarks are applied to the method. You are compared to the same people who are using the same method to submit that. So that's how kind of the logic behind it works. But what that really basically leads to is that most of you know, obviously, that there is an EHR certification, there's a 2014, there's a 2015 certification. As part of that certification, the EHR vendors have to certify for certain quality measures. Now, the EHR certification was actually finalized a lot before MIPS came in there. So what had happened was most of the EHRs were only certified for certain measures. They never had this idea about that we'll have to certify for a particular set of measures or so. But more importantly, that certification only covers the part where it reports the performance rate of a particular measure. So there's no relationship between the performance rate and MIPS in there. And I like to put it into a graph like this to say that the way the EHR certification and MIPS is, if you were to look at that pie and ask someone, is that healthy for me? I mean, you ask me any time of the day, I'll say, yeah, I'll eat it. I love pies. You ask my wife any day of the year, she'll say, no, it's not good for you. So the point being, the context is not there. I mean, like, you can't look at an individual performance rate that is being provided, by an EHR or by a particular measure and, just go with it. And with the reputation at stake and with everything going public in there, it's a big deal for those providers. So that's kind of where we came in. So last year when the final rule was announced, we launched an app called MyMipsScore in January. And then what app could do is it can basically take all the 271 quality measures, put them in the system in real time with some pretty slick analytics or so, pick out the best measures, the best method, do all that, things about it. We were the first one to come out with an app. We thought it was the best at that time. My opinion is biased. I still think it is the best one, but that's a discussion for another day. What I want to talk is, like, as we launched this app, as we started working with, there was one problem we ran into. So the app can analyze the data, the app can basically run, all those algorithms, but it is still dependent on the amount of data that we can get from the EHR. So these are the different, really integration methods, that you can go, unless you really go into a manual method, of integration or so. So as we started working with different, EHRs, most of the times it becomes cost prohibitive to actually integrate or build it to a point where we can get all the quality measures and do all that analysis in there. So that's kind of like the middle of the year. We were working with EHRs. We got like, okay, we got to reboot, we got to rethink, and that's where we thought, let's bring FHIR into the picture. So how did we basically use FHIR? So as you might know, that most of the EHRs are currently going under their certification process for 2015. Some of them did this year. Some of them actually are going to be doing it next year. Most of them are not going to be certified till end year. So the timing was perfect. So we went to many of the EHRs, mostly the ambulatory ones that we are working with, and we said, you already have to do these specific things that you have to do for MIPS. What if we just make a change there, and instead of you having to do it, we'll take care of it, but we will basically build the MyMipsScore app, and we will certify it where it is certified for all the quality measures, but then we will work with you to help you implement a FHIR server, implement the specification or so, where we can capture that data, we can capture all the data points from your EHR into the server, and then the rest of it is taken care of here. So the point again becomes is like that the EHRs can focus on the UI part, on the other parts, or whatever it is there. They don't have to recertify. There's a lot of work required around the quality measure certification, the IDs change or so. Take all that off, take all the logic off, take all the 2018 rule that is coming off, package it into a solution, put a plug-and-play solution to make it just work as a FHIR server. So, again, they get rid of the certification, they don't have to do it, but more importantly, as a selling point, you get all the analytics, and so that is built into MyMipsScore, now available to your client. So it's a win-win. I mean, it was a good revenue model that we can work on. The challenge again there was, which was like, is the effort to basically support now all that data points going to be more than what the EHR was going to just build it, anyway, or what is the current one? Because we are back to the same issue. Is like, if they want to report all that measures, you still need to get all that data. So what we did was, we did a little bit of cheating here. We took a little bit of shortcuts here, but the idea was, let's define a core set that will get us there, that will get us to most of the measures or the max measures to start with. And don't let perfect be the enemy of good enough. We can always, build from it. So what we did was, we started with the US core implementation guide. And that was really, really helpful, because all of the EHRs are already implementing CCDA. So we took whatever, entries, resources we could address as it is what was in the US core implementation guide, and implemented it to make sure all those resources are supported. And then we took to the second and the third step, where we took basically the definition files. The HQMF files are what are called as the E measures, the electronic measures for EHR. So we took every single measure, we went back, identified the data points, and we matched that back to the idea, what does it match to a particular FHIR resource. So create a list, comprehensive list, go back in there and say, okay, here is a list that we need to capture at a patient level. Once we have this list, we can basically support the certification, and we can confidently say that this is a particular performance rate for this measure, and we have all the data to determine that, and all the data to basically run the analytics across all the 271 measures to help the providers make that decision. Technically, kind of a little more, how did we actually implement it? So the idea there is that it is a single bundle that is equivalent to a CCDA, but I call it the CCDA on steroids. So there is one bundle which has one entry, which has one patient resource, but then based on the mappings and the other things that we identified with all the different data points, whether those are claims, whether those are procedures, problems, medications, whatever, those get added to as a single bundle. So that bundle is then, we build SDKs where we can take it to the EHR. We can just say, hey, let's just start with your code that is there to implement the CCDA, build on it, and we have the bundle from there. And kind of start and proceed where we go from there. So that was like, okay, this is good. But as we start to build the revenue model and other things in there, the idea was you got to see the bigger picture. We got to push the bigger picture to the EHR. So, okay, you've done this. You have an EHR, you have a PM, you have the FHIR bundles that are now connected in there, and you have the, the API. And of course, we did it because we want our app to work with it, and now the app can do it, all there. But in the process of doing that, because we have identified all the big, all the major data points, it becomes easier. Then now the EHR has much more options to connect all the apps in there. And again, everything that we have been seeing yesterday, today, it still depends on having that data in there. And we work with mostly like the ambulatory EHRs, where, FHIR is still not, that advanced. So this is kind of one way to say, let's put the plug of FHIR in. It gets us basically going there, and then, it also increases the scope of where we can go from there. So this is the pilot. This is kind of what we have been working on. Just to give a few pointers about the technology stack, behind it. So we started with some open source implementations, but we really wanted to make sure there were some validations. There were a lot of other things that we wanted to make sure there's included. So we built it from scratch, the server. It is based on an ASP, Microsoft ASP.NET Core with a backend of, Azure Cosmos, and the front end, it's available as an app on the phone. So we have functionality where, especially going into 2018, where these scores are going to be tracked for the whole year. So if it's a large organization, the provider can actually install the app, and every night or whatever, whatever frequency the data is being refreshed, they can even get the alerts for a practice level score, provider level score, a lot of, other alerts built in there, to go along with it. The current status, basically, so as I said, we have been doing some, pilot implementations. We are scheduled for our certification, so we have completed all the development. We have been running the tests, making sure also the week after next, we are actually scheduled for our certification where we are certifying all the eCQMs. We have already done all the registry integration that is required. And once that is done, our goal is that, okay, we build the FHIR specifications to back this up, but we are going to then try to integrate with existing FHIR implementation and see, there are some things where, what is a particular procedure or what is defined as, which is an observation. And so there's some mismatches that could be there between different implementations of, FHIR, and we're going to try to, standardize it more and more. So with that, I'm going to put a little, pop quiz here. So everyone in the room has probably seen this, right? We live this, we know this page at all. Does anyone know on this page, how many people in the room know where on this page is actually a QRDA or a quality specs, or anyone has used it on this page? Anyone knows if that even exists? You do, okay. So if you see on the last row, but like last but one, this is what is amazing about, kudos to whoever, the FHIR team or so. There is actually a resource defined for quality measure reporting for QRDA 1s and QRDA 3, which are basically the specs, and the way they're defined is the one that says measure 2 is the one which is actually you call on an operation function. So it's not really a get function, but you call an operation and it will give you back a QRDA 1, and the measure report 2 can basically give you a QRDA 3. So the idea is that it's already built in there, but again, that's still the same limitation that if someone is actually pushing that data, it is limited by the data that is there in the EHR or the data that was basically pushed for it. So our hope is that at some point as this grows, there will probably be a FHIR endpoint or so for the MIPS score itself. That's how we have implemented it in the system, that there is a get MIPS score point or so, and this can finally be extended to it. So I'll wrap it up with just again, I hope I wasn't too fast, but like there's a lot of content that goes behind it. So there's a couple of articles we wrote that I'll just share it here. The first one is It's basically how we have done the implementation, some of the lessons learned, how we are actually using it and doing it. And the second one goes a lot deeper into what is QRDAs, how they basically work, and kind of how we started the process, to wrap that up. So with that, I am right on time. Any questions?